All right. Next is Dr. Frank Wright, who will be giving a talk on disaster management for the surgeon. I can't think of anyone more qualified to do so. He went to a small university on the East Coast called Harvard for his undergraduate degree, and then went to USC. So there's a USC connection for medical school, did his general surgery training here at CU, and then went to Loyola to do his tax fellowship. So there are many reasons why I and we should be very proud of Dr. Wright. First of all, he's an excellent tax surgeon and a great teacher, but his leadership during the COVID pandemic was simply amazing and outstanding. And without him, I think this department of surgery and the hospital would be in much worse shape. So thank you for that. He's also a veteran and served as an active duty officer, as a major, saving our soldiers as well as local injured folks. And he really leads many of our critical care activities at UCH and leads multiple units in our hospital. So if there's an expert on this topic, it would be Dr. Wright, and we really look forward to your talk. Thank you.
Excuse me. Thank you for that kind introduction, Dr. Schulich. This is a very uplifting morning. Where's my clicker? Sorry. Oh, very uplifting morning. We talk about how little we're getting paid. Now we get to talk about what happens when the wheels fall off the bus. So important, just things to talk about, but not always the most cheerful. I have no disclosures related to this topic. What I'd like to talk about today is what are the surgical roles and strengths in disaster management? How do we plan and prepare for acute? And I'm actually going to talk about subacute disasters, which is somewhat of a new category that COVID has introduced us to. And then to summarize some of the major lessons learned from events such as mass shootings or COVID. So overview, what do we mean when we talk about a disaster? What does a disaster mean? How does an acute disaster look different from a subacute disaster? What do we do as a surgical group to plan and prepare for these events? How do we actually roll out in real time our action plans during these events? How do we recover from these events in the aftermath? And what big takeaways can we glean from past major incidents? So when we talk about disaster, we really are talking about the ratio of our resources, and that may be physical, manpower, et cetera, to the patients and the acuity level of the patients. So in a standard trauma situation, we have more than adequate resources to treat the patients and their acuity. As things get a little bit tighter, we start talking about a multiple casualty event. So now instead of one gunshot or MVC with a few patients, we start having multiple gunshots or multiple MVCs or a bus, and all of a sudden we're strained. And this looks different where you are in the country and where your institution is. So if you're at a critical access rural hospital on the Eastern Plains of Colorado, 2 gunshots or 3 patients from MVC may be overwhelming and may push you into a mass casualty event. At a major level 1 trauma center, hopefully those numbers that we can absorb are much higher, but we can still manage it and maintain our optimal standards of care. We're just stressed about it. Finally, we push over into a mass casualty event, or what's commonly abbreviated as MassCal, and now we do not have the resources to treat the patients in acuity that are coming in the door. And that's an important switch because we have to change our priorities and we have to change our mindset. In our day-to-day practice, we are all about taking the best care of an individual patient and doing everything in our power to make that patient that's sitting in front of us better. We can't have that mindset in a MassCal exercise. It no longer is about the patient that's sitting in front of us. It's about maximizing the survival for the greatest number of patients, because we know that not everyone is going to survive, and not everyone that in theory could have survived will survive, because we do not physically have the resources to make that happen. So again, when our casualties exceed our capacity or capability, we're in a mass casualty event. So acute disaster is what we're used to talking about. So we tend to have little or no advance notice. There tends to be a lot of misinformation. We hear a lot of rumors, and mass shootings certainly pop to mind as the most obvious example that we've seen an unfortunate amount of in America in the last 10 to 15 years. But major airline crashes, vehicle crashes, industrial explosions, terrorist attacks, bombings, chemical, biological, radioactive, we've been thankfully mostly able to avoid in the United States, but these are significant concerns for disaster events or major natural disasters, which we see less in Colorado, but in other parts of the country. And then this subacute concept is an extension. This is something that we haven't dealt with as much. Infectious, the COVID pandemic, what Children's is dealing with across the street right now, our partners over there are dealing with another respiratory outbreak. These take longer to brew to a head, but they also last for a lot longer. And so we have a little bit more ability to plan and mobilize our resources, but these events also tend to last for much longer. And so they bring their own challenges. So in preparation, we start by tabletop exercises is a great way, a bunch of people in the hospital or in the community sitting around the table and walking through scenarios and how we're going to deal with them. So that's a great first step of how we're going to roll out our response. Then we have to move on to actual drills. So sometimes we will say, on Wednesday morning from 8 to 9 a.m. in the emergency department, we're going to do a drill on a mass shooting or a plane crash. And we're going to actually walk through with pretend patients and actually sometimes even walk through the flow to get to the operating room and really practice that. Ideally, we involve our pre-hospital providers, our EMS, fire, and police into this system because they're a critical part. Pre-hospital really does play a very important role in these mass casualties. A great example was the Boston bombing. The advantage was it happened in Boston. There's a lot of hospitals, but that was a major event with major number of casualties, but this was the distribution of the initial patients and where they were sent. And you can see they spread the patients out across the major hospitals in a way that tried to prevent turning multiple casualty incident into a mass casualty event. So classically in the tactical, military, or disaster world, this is an ancient Greek philosopher's quote that is thrown around a lot, which is, we do not rise to the level of our expectations. Instead, we fall to the level of our training. So no matter how good we think we are, if we haven't practiced it and drilled it, we will not rise as well as we think we're going to do sitting around a room talking about it. So once we get there for implementation, we have to decide when we're going to activate our mass casualty plan. And again, with misinformation, that can be challenging. Sometimes we hear something horrible is going to happen and then not much happens, but we have to be willing to spin those processes up because they don't happen at the drop of a hat. We have to launch our incident command center because we really need people with ability to look out over the entire hospital and control the flow of information and patient care and resources. There's a lot of people that need to be spun up. So we have to notify all the people that may be involved, especially on this slide. The surgical phone tree is important. We have a TAC surgical phone tree that mobilizes our trauma resources, APPs, residents, and surgeons. There may be situations where we have to extend beyond that group, where we really need extra help, and we've got to make room. So that means stopping non-urgent care, dispositioning and getting people out of the hospital or the ER very quickly so that we can make room for incoming patients. So there was a major panel event that looked at these mass casualty events. There was a mix of both military mass casualty and civilian mass casualty. And the common themes from the panel discussion in how we respond to mass casualty is, the first one is assume non-traditional duties. So you don't necessarily get to, quote, stay in your lane. You've got to expand your practice. We've got to make space any way we can. We've got to continuously revisit, review, and re-triage people so that we're staying with accurate assessments. We have to have a plan to deal with the media, and we have to take care of our hospital staff. So we'll talk about some of the components of triage in overview. It needs to be accurate and effective. We have to talk about our triage officers. There needs to be one entry point. We need to have security. We need to reassess. So triage is a process and not a destination. I'll talk about this again. We have to be careful not to over triage, which carries its own dangers I'll talk about. And we have to keep up with our documentation, which can be an exceptional challenge in these mass cal events. So there is a central command that needs to be set up in the emergency department, and this will involve an emergency medicine physician, a trauma surgeon, the charge nurse or chief nurse, an OR liaison, and bed control. And this command center within the emergency department is in charge of maintaining and updating a master list and tracking board. We have a disaster tab now in Epic. It's sometimes very difficult to keep up with the EMR during these events, and we have to go back to paper whiteboard system. And sometimes we have to fall back on that to keep up with the volume. This command center needs to be the hub for communication coming in and coming out. Everyone in that group needs to know the latest and know what other patients are coming in and where patients are leaving to go. We need to prioritize. So again, with a large number of people, not everyone's going to get their chest x-ray right away. Certainly not everyone's going to get their CTs right away. Not everyone is going to roll up to the ICU when they are ready to roll up to the ICU. We have to triage and sort out who needs our resources in what order and in what fashion. Controlling entry is critically important. So we've got part of the triage is separating the walking wounded, the less severely injured, and setting up, you know, in this group, in this hospital, these rooms that are right outside the smaller conference rooms, maybe where some of our walking wounded end up. Families may end up in this room to try to reunite and get information on their injured loved ones. We have to deal with, unfortunately, the expected patients, the patients that we can't save. We ideally want to separate them from the major treatment areas, and we need to have staff there to help control their pain and provide comfort as able, knowing that we are saying that they are not salvageable in the current situation. We also have to, unfortunately, have a plan for in-hospital events. So if there is a shooting or a fire or an explosion in the hospital, that's obviously an incredibly traumatic event, but it also disrupts the patient flow. Everyone's not necessarily coming in through the emergency department anymore. People may be coming down back elevators and back hallways, and we have to plan ahead for how we're going to filter all those patients to go back through a single entry point. We also have seen in a lot of these events, non-medical drop-offs are rapidly increasing. So that means they're not being brought in by ambulance, by EMS. They're being thrown in a car and driven by their friend, or they're coming in police cars. As it happened in the Aurora shooting, the police were just grabbing people, throwing them in the cars and driving them to the hospital with no notification, no medical care. So we have to be prepared for that. The major goal of triage is to turn this chaos that is happening into an organized chaos. So when we talk about triage, the dime, these are the four categories we're talking about: yellow, red, green, and black. So again, delayed, may have life-threatening injuries, but we don't need to intervene in the first half hour necessarily. Immediate needs control of bleeding, of airway, or circulatory issues. You know, we've got to treat these patients at the highest priority. Minimal tend to be the walking wounded. We can sort them out when the most critically injured are assessed, and then expectant are people that we unfortunately don't think are going to be able to survive given the current resources. There's a few tools to do that. The SALT tool is kind of the classic proposed by the CDC in 2008 that's used by a lot of institutions in the United States. Again, how do we sort people into those four categories? So are they walking? Their lowest priority. Are they at least able to wave or make purposeful movements? Their second priority. People that are not moving or have an obvious threat to their life, we have to assess first. We do some simple interventions, opening their airway, stopping major hemorrhage, decompressing the chest. If it is a chemical biological attack, if there's an antidote, give them that, and then reassess. If those things have not salvaged the patient, they're dead. If they have, then we have to move down to, again, are they following commands? Do they have pulses? Are they not in respiratory distress? Have we controlled hemorrhage? And we have to decide again, even if any of those things they don't have, can we fix it in a timely fashion with our current resources? And if not, expectant. So this is one model. The START is a second model. It uses a few more explicit physiologic characteristics like respiratory rate and either the presence of a radial pulse or capillary refill to try to sort people. But however we get there, we need to sort them into those four categories. Once we do, we have to have a way to label them. Unfortunately, it's not going to be clean in the emergency room where one zone is all the red patients, one zone is all the yellow patients. As patients move in and out, we're going to be throwing them into beds, and we have to be able to keep track, and visual cues, even just kind of colored yellow rubber bands wrapped around patients' ankles or wrists, can really help us keep track of which patients are triaged to which level. Again, triage is a process, not an event, not a destination. We have to be able and willing to continuously reassess, upgrade, downgrade people, focusing first on life, then on salvage of limb, then on salvage of eyesight. And we have to start planning to restock the supplies and our personnel from the moment this starts. I mentioned over triage is a concern. So this is a study that looked back at 10 terrorist bombings over 26 years, and the over triage there on the x-axis rate had a direct linear correlation with overall mortality. In other words, we need to be very careful with our triage because over triaging actually worsens mortality. So if we declare everyone's immediate, everyone needs all the things done right away, in reality, nobody then gets the things done in a timely fashion. So we have to be very careful with how we assess who the sickest are and where we place our resources. Documentation is very challenging. I mentioned that we have a disaster tab that we have not had the chance to fully utilize that in a true mass casualty event. We will see how it goes. I would say we may have to fall back on clipboards, basic charting, and orders at bedside. As we all know from our experience, what's the success rate from in a normal situation of a patient consent done in the ED making it to pre-op? Not real high, right? So in a non-stressful situation, if we can't even get our consents from the ED to pre-op, how well do you think paper documentation is going to follow the patient from the ED to the OR to the ICU? Probably not real well. So using things like writing on the patient, writing their injuries and their resuscitation on the patient dressings. In the military, we would literally take the cloth tape and stick it to an uninjured body part and write the initial vitals, the transfusion requirements, and the procedures performed and the identified injuries on a piece of tape on the patient, because that doesn't get lost. No matter where the patient goes, we now have something written on them that is not going to be dislodged. And this is a kind of a classic example on an open abdomen of the resuscitation and what has been done during the initial operation. So to implement and perform well, again, we have to drill and train well and frequently. Damage control surgery, like many things in medicine, was all the rage. Then we had to step back and say, are we overutilizing it? In a mass cal, we are not going, we do not have to worry about overutilizing damage control surgery. We need to be doing damage control surgery. Blood product availability is going to be a limited resource. So anything we can do to limit and lessen our transfusions will help the most number of patients. Damage control surgery has that potential. We want to get in, we want to stop the bleeding, we want to stop contamination or spillage and get out of the OR with that patient so we can make room for the next patient. We also are going to need to do a more careful exploration. We may have surgical partners that don't do trauma X-laps every day or every week, and they can get in and stop the bleeding. And we may want to take that patient back in a day or two and more carefully explore and mobilize and look for more subtle injuries that we look for in trauma exploratory laparotomy. So the goal with mass cal situation is get in, stop the bleeding, stop the spillage from bowel or other hollow viscous, and get out of the operating room. The lessons from the Pulse nightclub, which was one of the more recent shootings, when they looked at the utilization of surgical groups, the general surgery / trauma groups, the vascular group, and orthopedic surgical groups were the groups that were most needed in that initial surge. Neurosurgical intervention, they actually did not have any surgical intervention in the first 24 hours. Now, again, that looks different in a mass shooting versus a bomb with a building collapse, right? Or a airplane crash where there may be a lot more spine, TBI issues, intracranial bleeds that may need surgical intervention. So the nature of the disaster does determine somewhat the need for surgical care. In the aftermath, again, we have to plan for our sequential surgeries. We may need to move patients in or out. We have to set up for the rest and recovery of our providers and our resupply. We need to do tertiaries on every single patient. We have to go over all the imaging. When people have looked at this, it's easy for the treating teams and even the radiologists to miss subtle findings on initial imaging because the volume and intensity that these images are being read under is incredibly high. So we need to go back and re-examine everything and then pick up on the things that we missed at our normal trauma evaluation. And we really have to focus on recovery for everyone that's been involved in this event. So that often means individual and group counseling, really focusing on team staff well-being. There's a lot of personal tragedy that's seen. There's fear for safety. There are very difficult decisions. Making that switch to focusing on all the patients instead of the patient in front of you is not something that comes natural to us, and it's something that brings a lot of moral distress and moral injury. And so we need a space to talk through that. So with those principles of acute management, I think it's useful to pivot to COVID because this was this kind of subacute disaster that we have not been involved with as much in our history. Planning looked different. We did have some early warning. We knew this was coming. We could sit down with the groups that needed to be involved and start making plans for how we were going to address this. Again, when we think about the multiple casualty incident transition to a mass casualty event, our goal was to try to keep us in a multiple casualty incident where we're all really stressed, but we can still provide what we consider to be optimum care to each patient, with the full knowledge that at any point we might tip over and end up in a mass casualty event. And what do we do? And what do we do differently when we make that switch? So part of the organization was how we're going to ramp up, but we also had to plan from the beginning how we were going to ramp down. We knew this was going to be a long-lasting event. This was not one night of terror. This was for us in April going into May, 50 to 60 ICU level COVID patients in 2020 for more than a month in that 50 to 60 patient range. And we had to be prepared to match that surge, but then also to ramp back down as things got better. We had to restructure our normal workflow and responsibilities and try to keep an eye on maintaining educational goals as an academic institution, is how we were going to have some educational benefit as well as providing the clinical flow we needed. We had to think about our external resource availability. Unfortunately, this was a international event. So our normal military federal response had to be looking at the entire country. We had to think about what state resources we had and what plans we could do to spin things up locally, understanding that this is not a one hospital problem. This is every hospital that is going to be confronting it. We also had to plan for austere care. So with all the resupply issues that we all experienced during COVID, what happens when we run out of critical items? And how do we replace those with others? And how do we plan for what we're going to do if we don't have enough ventilators? We also, overlying all of this is how do we make sure that we're all still staying safe, that we make it home to our families, and that our healthcare teams don't get sick as well. So in the implementation of this, again, looking at the themes that we talked about for the classic acute disasters, a lot of these themes still held true. We still had to look at how we assume non-traditional duties. We had to look at how we free up and utilize our space. We had to look up our triage teams and how we move patients to higher or lower levels of care, how we deal with the media, and how we take care of ourselves. As we spun up, we really left our pulmonologists as really our triage officers. They're our subject matter experts, and they really helped control flow of which patients were going to go to the ICU versus intermediate care versus ward. We also had to create pathways. So again, as we bring people out of their traditional duties, and especially in a disease that we were learning more and more about day by day, is how do we had to create pathways and protocols so that people that weren't as familiar with underlying respiratory issues could make the best informed decisions and implement the standards of care that we had. Procedural teams were a big part of this. So our anesthesia group was a huge part of this. We discovered very early on that when you had a decompensating COVID patient that needed to be intubated, they of course didn't just need to be intubated. They needed to be intubated, they needed a central line, they needed an arterial line. Especially in the first wave, this was all done with PAPRs and a lot of limitations on coming in and out of the room. So when you got a new patient that was decompensating, that tied up one or two people for easily 45 minutes to an hour, sometimes 2 hours on that one patient, on getting everything done that they needed to stabilize them. Now we've created this void where two of the healthcare team members on a very small team are now sucked up on one patient care. So having a procedural team that could come in, somebody could get the airway while somebody else is working on central line and arterial line. And these are These are people that aren't assigned with the minute-to-minute care of a bunch of other patients. They are just there to do the procedures needed to stabilize the patient. Was a big benefit in maintaining our ability to take the best optimal care of patients. We also had to adjust to new data as things came out. We didn't know the best ways to treat things. We didn't know if heated high flow or CPAP was a good idea or a bad idea versus going straight to intubation. We had to talk about tracheostomy timing and a number of other issues that I'll go through. So we had to be evolving to the best way to implement the most recent data, or not even data in some cases, just expert opinion. I will say the one bright spot was this was an amazing chance for collaboration. It really met the pillars of an academic medical institution. We were able to focus on multidisciplinary clinical care, research, and educational needs. So the ability to work shoulder to shoulder in the coal mine with our APPs, our pulmonary colleagues, our anesthesia colleagues, and our entire intensivist community was really powerful and very rewarding. But the flip side of that is, I'd say the biggest downside has been the aftermath. So unlike these acute cycles that things are very horrible but return to normal, this was chronic stress for everyone involved in the process. And everyone in the hospital, whether you were directly in the COVID ICU or not, we were all feeling that chronic stress, both in and out of the hospital. In the ICU, this cycle of reprieve, and in the wards too, and surgery as well, right? This cycle of reprieve, everything's getting better. We can try to do things a little bit more normally. And then all of a sudden there's a new wave and we have to re-enter into this. Was exceptionally stressful. I think the burnout and moral injury was very multifactorial, but very challenging. So we talk about, we had relatively healthy individuals and a decent percentage of patients that had this acute isolated decompensation that led to an immediate threat to life. We had issues with mortality rate, right? So if you look at our mortality rate in the CTICU, the STICU, in general, we're taking patients in, we're doing a surgery, we're getting them through it, or even a trauma, getting them through it. Our mortality rate was much lower than a MICU population would be, right? With a lot more chronic health conditions. And unfortunately, despite how well we did as an institution with really exceptional mortality rates with COVID, the COVID rates were still much higher. COVID mortality rates were still much higher than what most of us are used to seeing in our day-to-day practices in the CT or STICU. I mean, we were talking 1 or 2 mortalities a day on service compared to 1 or 2 in a week, right, in our normal lives. And that is very challenging. We were also being exposed to a lot of the socioeconomic and ethnic biases that are inherent in our healthcare system. And one of the studies that I did looking at COVID data, I looked at 40 or 50 patients that had COVID in the ICU, and less than 10% of those patients were Caucasian. And that's not our demographics in Colorado, right? In that first wave, we were seeing an overwhelming number of minority and socioeconomically disadvantaged populations in our ICU, and that carries its own moral injury and burnout stress. We also all had personal and family health concerns. Were we going to get sick? Were we going to bring this home to our families? And I think the area that's been the most challenging is, how did we deal with the aftermath, and how did we deal with this burnout? I think, again, the one good thing is it's really broken down the stigma of therapy. A lot of people involved in this are in therapy and talking through some of it, or had to go to therapy, and I think that's important to deal with these situations. I'm running out of time, so I'll go quickly through the ethical dilemmas. We had hours of conversation about, should we split ventilators? Ultimately, in keeping with the principles of mass casualty, we'd rather focus on providing optimal care to 1 patient than very poor care to 2 patients. But that was a big topic we had to consider. A lot of us looked at the anticoagulation needs for these patients. We had to discuss tracheostomy timing in the role, risks with chest tubes, which is not a closed system, and how we were going to address that. And then in that switch from multiple casualty to mass casualty event, because this was so chronic, these decisions weren't split second. They actually had to fall under Colorado statutes. And could we be called crisis standards of care? And could we actually morally, ethically, and more importantly, legally in this case, provide mass cal standards of care, which thankfully we were able to avoid. So wrapping up, last slides, lessons learned. We know in the acute care setting, in the acute disaster, Getting blood early, getting handed off to a surgical team early improves survival. One of the huge lessons we've learned with mass casualty events in the last 10 to 15 years is stick an experienced trauma surgeon in the ED very early on, and they stay there. They're not taking patients to the operating room. They're managing flow, and they're making critical care decisions in the ED and handing off the patients to other people. So from surgeons, we have to expand our roles, stretch our comfort zone. We are part of the surge capacity. If we get 40 gunshot wounds, you better bet that we're going to be calling pulmonary critical care and anesthesia to come help us. In the same time, when the hospital is overwhelmed, they're going to call us to help them. And that seems very appropriate for maintaining optimal patient care. We have to maintain our best possible patient care for the usual patients we take care of. We can support procedures. And I really did want to put a shout out of thanks to this department. Our CT, ST, ICU burn units really fell on the sword to really help take care of these patients. Our residents and the residency program were incredibly supportive during this process. Our APP faculty were really a backbone, especially in the ICU. Our CT surgeons did ECMO and figured out ECMO plans. Our vascular surgeons were overwhelmed by the clotting complications. Our GITE surgical oncology group stepped in to make a backup plan for if the TAC surgeons need to go exclusively to ICU, and the leadership of the Department of Surgery was incredibly supportive of doing everything we can to optimize patient care. So a lot of thanks.